Now we should be showing live. You have 10 minutes to start. Thank you guys. Thanks Dima. Salam. Thanks Dr. Mazen. Thank you guys. 4 minutes we'll be starting our live session. Thanks Dr. Wad. Hi Zahir. Hi Namr. Okay, I think now it's 1 o'clock. We should be starting. Hello, everyone. Hello, dear friends. This is Mohammed Za'afrany from Egypt, and today it's my pleasure to be with you in this live webinar. Actually, I like to take the chance to thank ET's company for giving me this opportunity to be with you today in this series of live sessions. Great effort in the background to make this event possible. So thanks everyone who is behind this great success. And before starting, I'd like to introduce myself. I'm Mohammed Za'afrany from Egypt. I'm a gold member for Lateral Endodontics, speaker on behalf of Dentist Supply Serona Endodontics and Zomax Medical Company. I'm a director of endodontic program at MedLink Dental Training Center. Also, I'm a clinical trainer in Delta Plus Delta University for the clinical attachment program. And before going to my talk today will be about perforation, but I want to focus on a very important point. Many times on different educational platforms, in social media, in congresses, in dental conferences on ground, we can feel the fight between endodontist and implantologist. As if we are going in two different ways, which is not a reality. Endodontists are doing great job trying to save teeth, doing treatment for management of mishaps, but sometimes we take it to quite extreme level, saving hopeless teeth or trying to save hopeless teeth. Doing treatment in a teeth which should be extracted and implant take place. After doing treatment, the tooth break down, start to have some bone loss, some bone resorption, and now situation become more difficult to the implantologist to place his implant. Now situation become more challenging. On the other hand, some implantologists also prefer to extract some teeth which could be saved by conventional endodontic treatment. It's not because endo is not indicated, but because this is a treatment I can do. So we're not offering post-treatment equal, either for endo or for implant. However, we are running in the same circle. We are healthcare provider. That's why we should provide treatment options equally. Endo and implant are not a competitive therapy. They are a complementary treatment options. So it is very important to implantologists to know about endo, also endodontists to know about implant, and which time, according to the clinical judgment, which time should be the treatment option to be done. Now I go to my topic. Topic is about management of endodontic perforations. My lecture will take you from some basic knowledge to the most advanced situation and how to manage this situation in your daily practice. This is a lecture frame. We will speak about definition, what is perforation, how to diagnose perforation, factors affecting prognosis, and material used for the repair, and some cases for management. And actually in this management section we'll see many tips and tricks to manage this difficult situation. So what's perforation? Perforation is an artificial communication between the root canal system and supporting tissue or the oral cavity. Actually, perforation itself should not be that harm to the patient, or it should not cause that irreversible inflammation or irreversible damage. Using files or pairs causing perforation, causing mechanical trauma to the supporting structure, this should be a reversible process. But the problem is the bacterial invasion to the perforation site. When bacteria invade and suppuration happen, abscess formation, sinus tract, and bone loss, this media and this situation is not that good for our root repair material to be in place and complete the healing process. So not all perforations that happen is because of iatrogenic perforation. We can see perforation during access cavity happened or occurred in the coronal portion of the tooth during trying to locate the canals, during post-space preparation, sometimes trying to negotiate narrow canals or calcified canals, you might do perforation. During removal or retrieval of separated file using ultrasonics in improper way, you might end up also by perforation. All these reasons are iatrogenics, means it's caused by the practitioner or the clinician. However, we have also some pathological reason for perforation, like internal or external root resorption, coronal decay that might extend to the bulb floor. As we can see in this case on right side, we can see a radiograph. Here is internal resorption that clearly seen or clearly showing it's extended to the supporting structure or the perdention. On the radiograph on the left, we can see the internal resorption, but it is not clear in this radiograph if it is perforating or not. Here comes the role of cone beam CT. I'll show you now the CBCT for this case. As we can see here, in mesolingual canal, we have internal resorption, which is not perforating. However, if we go a deeper level, we can see here the internal resorption in mesobuccal canal, and it is perforating both sides of the mesial root. So cone beam CT might be indicated in case of perforation for evaluation of the extension. Okay, speaking about coronal perforation, we'll take it chronoepically. Coronal perforation that might happen during access cavity preparation, especially in cases of recession of the pulp chamber. If the pulp chamber is quite deep and you're trying to get through the pulp, you will not find the canal easily. You start to misalign your pair during entrance, and this might end up by a coronal perforation or perforation in the crown. And this could be avoided by estimating the length between the coronal surface or the occlusal surface of the tooth to the pulp chamber, and then mark it on the used pair. So when you go, you know how much the length needed to go through the pulp, and you will not exceed that length. And anytime you feel doubt that you're going in wrong direction, you can stop, put a radio opaque material like calcium hydroxide or bioceramic sealer inside the drilled space, then take a radiograph. The material will appear radio opaque on the radiograph, so you know where are you going. If you are going the right way, you can continue. If you are not going right way and you're going off route, you can correct yourself at the needed time. Coronal perforation mostly happen in upper anterior teeth due to neglection of its inclination to the orientation or the inclination of the tooth. We all know that maxillary anterior teeth are inclined palatally. So the usual way to open access in these teeth, we start perpendicular to the lingual, the palatal aspect of the tooth, till we go through dentine or getting dropped through into the pulp. Then we go parallel to the long axis of the tooth to have a straight access to the radicular portion of the pulp. But if you did not respect this anatomy or this inclination, you might end up by perforation to the coronal portion of the maxillary anterior teeth. In this study, clinical study of evaluating 55 cases of root perforation, the nice finding that all anterior teeth were perforated in the labial aspect because of the operator underestimation of the palatal root inclination. This is very important. Sometimes this happens with beginners, and sometimes the overconfidence from experts might lead to this situation. So it is very important to take care which is the right way or the inclination of the maxillary anterior teeth, so you can go through into the pulp. Coronal perforation also could happen during access opening in tilted teeth. So if you have a tilted teeth, clearly in the radiograph, especially if you are going through a prosthetic crown, which should not happen. If you have prosthetic crown, you should remove before going into the pulp or into endodontic treatment. This crown should be removed, so you better see the actual occlusal surface of the tooth, not the prosthetic one. So if you go perpendicular to what you believe in patient mouth and the occlusal table, you might end up by perforation, while you should analyze the pre-apical radiograph, check how is the inclination of the tooth, and go perpendicular or parallel to the non-occlusive tooth, so you'll be in the right direction. So it is very important to pay attention to tooth inclination during access cavity preparation. What about floor perforation? Floor perforation mostly happens during trying to locate hidden canals, or you're in the pulp space, but you're not able to locate one of the canals. So you start to neglect the floor map, which guide you where are the canals, and you start to dig into the floor, ending up by perforation. Here, here comes the advantage of using magnification, either loop or microscope, to locate these hidden canals. It's very important also to take care of the anatomy, look well to the anatomy. Where is the mesial canals? Where should be the distal canals? Knowledge of the anatomy will help you how to do great job and do access cavity in these cases without causing or perforation. Floor perforation also might happen during post placement, like we see in this case. This is a misaligned post or post which poorly placed, here perforating into the floor. We all know that lower molars may represented by 3 canals, 2 mesial, 1 distal, or 4 canals, maybe also 5 canals. But what if you know that some mandibular molars, like lower first molar or second molar, might exhibit lower number of the canals? It might come with 2 canals, 1 canal, or either C-shaped canals. The percentage of 2 canals of lower second molar range from 3.5 to 20%. So if you are dealing with a case like this is lower second molar. This is referred to me because dentist was not able to locate the third canal, which is the mesolingual. He started to use his pair trying to locate, but it was good that he stopped at the right time. If we take a look at the floor of this lower molar, there is no guide to tell me I should clear here, or do reduction here. If I have another canal in the mesial root, it should be in the same entrance. So no need to dig here. The floor map is clear. 1 canal mesial, 1 distal, and the floor map clearly guide that there is no other canals in other places. So no need to this dig. That was good that the dentist stopped at the right time without causing perforation. This is the case. It's only 2 canals in lower second molar. Again, the dark side of social media. MB2 is always there. Please take care of this kind of statements. MB2 is always there. MB2 is not always there. So if you see some statement like this, MB2 is always there, and you start to believe that MB2 is always there, you will not leave the tooth until you find MB2. However, MB2 is not always there. I like this worldwide study of the prevalence of maxillary first, the MB2 in maxillary first molar. It shows that the MB2 prevalence range from 48% to 97.6%, with a worldwide global prevalence of 73.8%. So MB2 is not always there. Yes, you have to look, you have to try to find, you have to use the needed method or the known method trying to locate this canal, but it is not always there. If you keep digging, trying to get the canal, you might end up by this kind of perforation, and you're searching for MB2. No, many cases I'm treating, and all endodontists treating exhibit only or represented in the mesiobuccal by 1 mesiobuccal canal only, and there is no MB2. Here comes the role of magnification and ultrasonics. If you are trying to locate canals or searching for canals, you need the right tools. Either you can use the eye loop or microscope, trying to dig through isthmuses, going through isthmuses. Actually, with ultrasonics, you can see clearly where the tip is cutting. You can do cutting in a more precise way. No more reduction to tooth structure. So you can refine your axis, you can clean, and you can access or try to find MB2 in a proper way without too much destruction to the tooth structure. Here we can see the isthmus between MP1 and MP2 is clean using suitable probe, the DG16 probe. You can check for any catch like we find here MP2. This is the canal entrance. We can start to negotiate. So using the right tool also will make you avoid this kind of perforation inside the floor. What about stripping perforation? Actually, stripping perforation happens because a clinician don't know that dentine thickness in different places in the root are different. It is not the same. We have what we call the danger zone, which is close to the forcation area, and we have the safe zone with more amount of dentine. So we should respect this during post-space preparation, during using of rotary files with large taper. If we are going to do any kind of brushing motion, we should avoid this kind of brushing motion at this side, because at this side towards the forcation we have thin dentine. So we can easily denude this area from dentine ending up by perforation at this side. If we're going to do some brushing motion or using even flaring file during first phase of shaping, you need to do brushing motion toward the safe zone, which is towards the outer wall, which is having a thick dentine or more thickness of dentine, so it is more safe. Here it's clear in this cross section how the dentine thickness from this side is very thin, so you need to avoid any preparation or make your preparation towards this side. This will be more safer. In this photo we can see this is a mesial root of lower molar. Here this is a distal aspect of the mesial root. Clearly we can see this getaperca. This surface is stripped. All dentine in this area is removed during preparation. That's why you can see getaperca from this aspect of the tooth. So it is very important to try to avoid and respect the dentine thickness in different area of the tooth. In this case, with the coronal curvature, as we can see here, I have a multiplanar curvature, this coronal one and apical curvature. Actually, I did shaping to this tooth many years ago. That time, no flexible files, or as we call them, martensitic or controlled memory files. So I have to take care to manage this case using shape memory files or austenitic file. These files relatively doesn't respect the root canal anatomy because it has a shape memory. So if you're going to prepare cases like this, it's easy to do string perforation here at this side because the file tend to regain its shape. So it will do uneven reduction, removing more from the outer curvature apically and from the inner curvature coronally. That's why the use of super flexible files will make you avoid such stripping perforation error during treatment of such cases. What about lateral root canal perforation? For sure this happened during root canal shaping. It's always preceded by a ledge. Mostly you'll find the ledge before having this kind of perforation. This perforation, to avoid, you need to develop your skill to master root canal shaping. Like this study done in Saudi Arabia, it was discussing the factor responsible for endodontic treatment failure. And the conclusion of this study was the lack of knowledge and lack of continuing education courses on the part of general dental practitioner was the main reason to have endodontic failure or endodontic mishaps. So you should get trained, you should try to develop your skills, you should attend courses, okay? I'll be waiting for you in my courses. to develop your skill to try to avoid this error during shaping. Lateral root canal perforation also can happen during management of separated instrument using ultrasonics. If you can see in this case, I have here a separated file, and this ledge is represented by the work of ultrasonic by previous dentist. According to the patient, he had this tooth treated 2 times and he asked for extraction. What do you think is the reason for this lesion at this site? What do you think? Actually, I don't have to think too much because this tooth I will extract, so I can evaluate after extraction. And this is the situation after extraction. I can clearly see here the place which the previous doctor tried to remove the separated file, and he dig into the outer wall, he caused perforation, and the perforation was responsible about this failure. I would recommend in cases like this, we have a type 2 canals. If I have separate instrument in this canal and already you can bypass it, or already it is bypassed from the other canal entry, leaving this instrument in place and obturate above the level of the file, I think we might have a better outcome than trying to retrieve this file from the root causing perforation. This is a perforation. Here I place the file and I took a radiograph to make it more clear where is the perforation, and it was evident that perforation during the use of ultrasonics affects the treatment outcome, and at the end we extract the tooth. In this case also we have separated instrument in this lower molar with long root. We can see that we have a lesion at the mesial aspect of the tooth. The lesion represented also by a perforation. Here we have a perforation, and if we take a deep look, we can find here that this is a straight axis which the previous doctor tried to use ultrasonics to remove this piece of instrument. Using ultrasonics inside canal is very dangerous if improperly used. And this situation also can happen with beginners and with professionals who just feel if I have ultrasonic tips and I have magnification, I can easily remove instruments. No, it is not that easy, and it needs training. So if I use ultrasonic tip this way without magnification, I might end up by perforation. Now I have a complex situation. I have a perforation and separated instrument. I need to deal with both. But if I'm using the ultrasonic tip under proper magnification as a microscope or loop, if I have separated instrument in the coronal 1/3, I might give a proper treatment for the patient with good quality. Sometimes we need to pre-curve our ultrasonic tips to start to work on the inner wall to make removal of this instrument more easy. So, what are the prognostic factors or factors that affect the prognosis of endodontic perforation? We have many factors: time, size, site, and the preoperative periodontal probing. For sure, the skills of clinician and the clinical judgment also affect the prognosis of endodontic treatment. Okay, what about the time? Here we mean by time, the time between the occurrence of perforation and the time of treatment, this interval. If we have a recent perforation and we treat it as the same visit, the treatment outcome will be better, rather than if we have an old perforation. Here we have a pus formation, we have breakdown to epithelial attachment, we have epithelial perforation, we have pus. So at this situation, we have poor prognosis. If we apply our root repair material, we might have poor prognosis in this situation. So it is very important to seal perforation as early as possible, as early as you can, not to reach to this stage of bone resorption and bone loss. In this study, which is a very famous study of Samuel Stelzer, they stated that most severe reactions occurred when the perforated region were not closed immediately. Most severe reactions occurred when the perforated regions were not closed immediately. That's why it is a prognostic factor. Time is a prognostic factor. It is better to seal the perforation as immediate as possible. What about the site? We have coronal, cervical, apical perforations. The worst scenario is that if we have a cervical perforation at the crystal area is called the critical zone. If you have perforation at these areas, the prognosis is not good because of the proximity of these areas to the sulcus, to the periodontal, to the periodontal, because of proximity of this area of perforation to the gingival sulcus. So you have a communication between area of perforation and oral fluids and bacteria. So this might affect the prognosis, and also it will lead to, mostly will lead to washout of the repair material. However, having an apical perforation would be having better prognosis. So here in these areas, application of rootable material might be easy, but it will exhibit or represent poor prognosis. However, more apical perforation might be difficult in application of rootable material, but it will show better prognosis. Here in this study about classification and treatment choices based in prognostic factor, it shows that close proximity of the perforation to the gingival sulcus can lead to contamination of the perforation with bacteria. And crystal area might be also apically. In cases of gingival recession, you might find it more apically. Here, as we see, if we have a perforation at this site, we have close proximity to the gingival sulcus, so prognosis is poor. However, here we have a large space or big space between the gingival sulcus and the perforation. So in this case, we have a better prognosis. What about the size of perforation? For sure, small size perforation shows better or good prognosis rather than big size perforation. In this study by Fabio Gorni et al., it shows that perforation with size less than 2 millimeter show no failure after treatment. However, with size 2 millimeter to 3 millimeter, it shows 6% of failure, and larger than 3 millimeter, 16% of failure. So from that also we can evaluate the treatment before starting. We can know how is the size of the perforation, where is the location, how long time between the perforation occurrence and the treatment. By that we can judge how is the prognosis of the treatment. One more factor also is a preoperative depth of probing. Probing more than 4 millimeter close to the perforation site will show poor prognosis in case of perforation. That's why positive periodontal probing, the preoperative positive periodontal probing, result in higher risk of recurrence. So we can summarize the factor affecting the prognosis of treatment of perforation, like perforation location, time of repair, and size. We have favorable prognosis if we have a perforation apically, if we did immediate repair to the perforation, if we have a small size perforation, and we have unfavorable prognosis if we have a crystal or cervical perforation, if we delayed the treatment of perforation, and if we have it large. How to diagnose perforation? Now we know how perforation happens, how the prognostic factors that determine the treatment outcome in case of perforation. Let's see now how to diagnose endodontic perforation. First, by radiographs. We can see here in this pre-apical radiographs, this is a fiber post. It's shown clearly the fiber post with a lesion related to the place of the fiber post. In this metal post also present infarction. Here we can see the digging inside the floor of the pulp chamber ending by perforation, and we have here also breakdown or bone loss. Here also we can see that the previous dentist started to dig using bears inside the mesial root, trying to locate the mesial canals, so radiograph can could help for sure to diagnose root perforation. Clinical inspection, and here magnification might show a great importance of inspecting floor of pulp chamber, or maybe sometimes in the root we can see the perforation clearly. Placing getaperca or file inside perforation and take a radiograph. By that also we can confirm if we have perforation or not. Sometimes you work in a regular way, you don't have a problem, and you're surprised by presence of blood. You start to think this from the pulp tissue or this is a perforation. At this time you can stop, especially if you feel that you are having a blood shorter of the working length. You can stop, place file or get a Becker cone to confirm that you have a perforation. Epicallocators also is of great importance. It could help you to diagnose if you have perforation or not. On the right side, I'll show you how the epicallocator should behave in cases of normal canal without perforation. When you place the file, as you go deeper, you have a gradual decrease. Let me show it again. You'll find this tip, you go deeper, you find gradual decrease in the reading till you reach to the apex. However, in cases of perforation, when you place the fine perforation, you'll not find this gradual decrease. Suddenly, you'll find that your epicallocator will show that you are outside the root or you are in perforation. So, epicallocators would help you to diagnose also a perforation. CBCT. In cases like this, if you have a case like this and you start to evaluate the treatment, in this case, you have short obturation. Seems to be easy. You remove this getaperca reaching to the working length, but the problem that in CBCT we have another dimension. We can see that this is not in the canal. This is outside. This is a perforation. So CBCT also is of great importance to diagnose perforation. Also, it will provide you with the actual size and site of perforation so you can apply your treatment in a better way. Bleeding spot and paper point. Especially if you have a stripping perforation, you might be having this bleeding spot on lateral side of the paper point. Here also from this slide you can know where exactly is the perforation. From this slide you know where exactly is the perforation. So when you apply your treatment or you apply your getaperca or your rootable material, you know exactly what you are doing. But we have to differentiate between presence of getaperca, presence of bleeding on lateral side of the paper point in cases of stripping or in cases of lateral canals. Sometimes we have this kind of lateral canals which is bleeding, and you see that there is a blood on lateral side of the paper point. You think this is a perforation. Sometimes it's not a perforation, it is a lateral canal. So we need to differentiate between the two situations. In this case, here we have a perforation, stripping perforation. It was clearly shown while I'm drying the canal that I have a perforation. This perforation happened due to disrespect from previous dentist to the root thickness at this zone. This is the anatomy of the canal, and this is the file. See how it's placed. No respect to the canal anatomy, no respect to dentine thickness, so it ended up by this kind of perforation. I showed you many types of perforations and how to diagnose and how to know that you are dealing with perforation. Now we'll speak about the material used for perforation repair. In this article, a review article about perforation repair material, they showed more than 23 material were already used for perforation repair. But nowadays, we're using the calcium silicate cements. For me, I'm using MTA. It is a calcium silicate based material. MTA has high pH, which show antibacterial properties and biocompatibility. It is a material which is dimensionally stable, so it provides better sealability at perforation site, And mostly when we are dealing with perforations, we have like moisture, maybe bleeding. That's why we need the hydrophilic material to sit in the presence of moisture. So MTA is preferred. Sometimes I'm using also bioceramic, the putty material, not the sealer, just to confirm. I'm using bioceramic putty material, and biodentin also could be used. But it is not enough to have the material and the perforation. You need a carrier to deliver MTA to a perforated site. And for carriers, we have different types of carrier, Dovgan carriers, map system. For me, I prefer the use of map system. MTA is a material which we can apply in many situations. We can use it as an apical plug for lateral root perforation, for epixification, for pulp capping, partial pulpotomy. So we need a tool that can help us to deliver the material in the needed place. It is not enough also to have the material and the carrier. You need some accessories like plugger to adapt the getaperca to perforation site. You need some micro brush for better adaptation of material as a perforation margin. I'll show you some cases where we used all these tools for sealing perforation. And sometimes also we need paper points for compaction of getaperca, especially if we have too much of moisture at the perforation site. You might need to adapt your material using paper point, so any excess moisture you can absorb. In some cases, and I feel like I need that material, which is fibrin, gelatin, or collagen sponge, which is a resorbable material. In cases of large perforations, sometimes you don't have good control on placing the root repair material. That's why we need a matrix. We need a matrix to place below the perforation margins. Then we can adapt our MTA or our root repair material to that site, so we'll be having better control of material application. And this sponge is resorbable. Within 2 to 3 weeks, it will not be there. I'll show you in this case of open apex how we apply this sponge, and the same way we can apply in cases of perforation. This is a collagen sponge. After determining the working length and where I should apply, till which length I should apply my apical matrix, I marked the length on a plugger. I started to push the material, to push the sponge to apical to the perforation margin, and you should confirm that all the sponge, all the fibrin present apical to the margin, not inside the canal. Inside the canal, it will resorb, so it might provide leakage. I need to adapt the material apically, confirm that it is below the margin of perforation. This way, I am having good apical matrix or good matrix. Same technique we can use for lateral root perforation. This is the MTA, and we can see clearly here in this plunder pass apex, I have good control on MTA placement, followed by getaperca placement over the MTA. I want to focus on one important point here regarding the disinfection of perforation site. We can use sodium hypochlorite. I prefer using sodium hypochlorite at low concentration, like 2.5 to 3%. Just you need to flush the site of perforation. You need to remove the granulation tissue. You need to remove the organic component of the tissue which might present in a perforation site. So I like to use sodium hypochlorite in low concentration just by flushing to the site. No positive injection of the material of the irrigant inside the perforation. And one important point in cases of lateral root perforation, you need to use your lateral vented needle in an opposite direction to perforation site. So if I have perforation in this area, I have to confirm that my vent is in the opposite side, because if I place it and it is the same side as perforation, I might push the material or force the material into the potentium, causing a hypochlorite accident. So it is very important to avoid this situation. Now we'll go through some cases. We'll see some cases of coronal perforation, some cases of floor and lateral root perforation. After that, we can take question. Yes, we can take questions and reply. Okay. This case, we have coronal perforation here and growth of gingiva inside the perforation. In cases like this, we need to do excision to the overgrowth gingiva inside the tooth. Just we need to remove. Excision could be done by excavator. After that, we need to protect our canals, and that time we can't use MTA for sealing perforation in the coronal portion. We need to use material like glass ionomer or composite. We just need to place our matrix here and deal with the case as a carious lesion. At this side, after cleaning, just place your matrix, your wedge, and start to adapt your restorative material, either glass ionomer or composite at this side. And this is the situation. We have the material sealed. Now canals are ready to be cleaned and shaped. Sometimes in cases of coronal perforation, we might need to do some sort of crown lengthening to respect the biological width. If we're placing material at this side, we need to respect biological width. Another case where we're having getaperca extended from the perforation site into crown into the bone. So at cases like this, we need to, after removing the crown for sure, we need to pull this piece of getaperca very gently. Don't do forces while you're pulling, so you did not get this getaperca cut inside the bone. What happened with me is that I got this getaperca cut. Here it got cut during removal, and here I did my build up. I treated perforation with composite build up because I was having good control on moisture. And this is the case. Perforation is sealed. This piece of getaperca removed after that by flap surgery before fabrication of crown. And this is the case. We have treated the perforation, the coronal perforation. We have did good endodontic treatment to the patient without any complication. What about cases of floor perforation? I'll show you 3 cases of floor perforation and how we deal with this kind of perforation in different way. This case was referred to me because dentist did perforation in the floor of the pulpit chamber of this lower second premolar with 2 roots. This is the situation. This is the canal he already detected. This is the perforation site, and for him, as he was not using any kind of magnification, he could not locate this canal. By magnification, it was easy for me to locate the other canal. So now I'm having 2 canals, and this is the perforation in between. By the way, while he tried to remove this getaperca from the perforation, he got some piece of getaperca cut. Actually, we don't need to deal with this getaperca now. Getaperca should be sterile at the time he tried to take working length by this getaperca or try to estimate how is the situation using getaperca. So unless it is not causing a problem, we can leave getaperca in place. This is after placing MTA, applying MTA to the perforation site. Okay, now I have 2 options. Before this situation, I have 2 options. But for sure, I need to repair the perforation as fast or as immediate as possible. The 2 options, either to protect the canals by some sort of Teflon tape or paper point during application of MTA to perforation site, or protect the perforation site by Teflon during obturation of these 2 canals. In this case, I'll show you what exactly I did. This is the case, 2 canals and the perforation. Now I place paper point inside the perforation just to show you that this is a perforation, not a canal. Here is bleeding. Okay. Now I will protect the other canals using paper point. For sure, you can protect it also using Teflon tape. First canal, the second canal. After placing paper point, I need to confirm I have good access to perforation site to apply my root repair material. Now I confirm that I'm having good access to perforation site. I'll start to apply MTA using map system. First increment. Then using paper point or using plugger, whatever suitable for you, you can gently compact or adapt the material. If you have a small perforation, you can apply without using of apical matrix or fibrin. But if you feel you're having poor control on MTA application, you can place some sort of apical matrix beyond the perforation level. Third increment of MTA. Now by use of micro brush, I can adapt the material better to perforation margins. Now I'm ready to remove the paper points from the canals. I place wet cotton palette, temporary filling, and next visit I confirm MTA has set. Then I apply my obturation and two posts placed in place. Another case of floor perforation. When this patient came to me, actually my first treatment option for this patient, I offered to him to do extraction. From a clinical judgment, this tooth seems to be unrestorable, but patient was highly motivated to keep the tooth. At that time, don't give promises to the patient that you can save the tooth. First, you need to remove the caries, check how is the perforation, check if you find the canals or not, then you can start your treatment. In this kind of situation, for the patient, do more but promise little. Do more to save the tooth, to make it live for longer time, but give the patient little promises, because from the site and the size of perforation, you can say that you have a poor prognosis. In this case, I did evaluation under split dam, remove the caries, refine the perforation site. Now I need to locate the distal canals. Here also, if you can see here the dentist used a bear trying to locate the hidden canals or the mesial canals, which he was not able to locate. Now I located the distal canals, I have perforation site. Now I have either two options, either to protect the canals during perforation repair or to protect the perforation site during obturation. Here I placed sterile Teflon to the perforation site. I finished obturation to the canals, and I placed like a flowable composite, just thin layer flow composite over the getaperca. Now I have only the perforation site I need to repair using MTA, and it was easy to apply MTA in this situation. And this is a final restoration or final coronal seal, and this is the case. Another case of floor perforation. This is a bone. If you can see here, the dentist tried to locate distal canals. He located the mesials, but for distals he could not find. He started to dig in the floor without any guide, without any kind of magnification. It ended up by a perforation. And if we take a deep look, you'll find that he started to place files and prepare canals in the bone, which is wrong. Here's the perforation. After locating the canals, I placed sterile Teflon to perforation site. Then I finished my obturation. Now, obturation site is ready to receive my root repair material, and in this case, I used a bioceramic putty material to repair the perforation. This is the case after treatment. You can see here, this is a rootable material, it's a bioceramic, and actually we don't have a problem if we have extended material inside the prudentium. The material is very biocompatible. The material is osteogenic, osteoinductive, and osteoconductive. So we don't have a problem from over-extrusion, but we should try to avoid this extrusion. Rootable material and canal obturation should be limited only to the root canal space. There should not be any extension or extrusion in the periodontium. Another case, if you have a look at this case, we have multiple errors. Imagine this case come to you with a broken file, separated file, to be more precise. You have separated file, you have perforation in the floor with overextended getaperca into the perforation site. We have a missed distal canal. Many of us might decide to extract this tooth with multiple mishaps. We might think to remove or extract, but if you know the management of each single situation, I think we can provide good treatment to the patient. Separated file beyond the curvature, it is better to bypass, not to retrieve. For the perforation, we need to remove this piece of getaperca, and as I said, we need to pull it gently so it did not get cut during treatment. And for locating the distobuccal canal, I think it's easy to do. This is the case. Here, I bypassed the separated instrument, the separated file. I could be able to reach the working length. I removed the getaperca completely from the perforation site. I located the distobuccal canal, and this is the treatment. Same also, I protect the perforation site by Teflon till I finished obturation. After that, I placed my MTA to perforation site, and this is the case. We saved the case with multiple mishaps because we know how to manage or how to deal with this kind of errors during treatment. Now we'll go to lateral root canal perforation. This case I'm showing to you, this is a case of retreatment. And actually, I'm the one who did the perforation. Yes, underestimation, overconfidence, self-confidence might end up at the end by an error. This tooth, I did perforation because of the poor accessibility to the getaperca. I felt I'll go through the getaperca using rotary files and it will be easy to remove, but I applied force. I don't have straight access to getaperca. I ended up by perforation. So now I need to deal with the perforation and need to remove the getaperca. Now situation is more worse. After pre-curving my files, trying to reach to this part of getaperca, I was not able unless I flare the file coronal to the perforation. I try to do more brushing at this side, so I have now more straighter access to the getaperca. I was able to remove getaperca. Now I have the canal, I have the perforation. I need to obturate the canal just apical to the perforation level. As you can see here, I obturated the canal just apical to perforation level. Then I need to apply my MTA at this side of the canal to repair the perforation, and either to fill the whole canal with getaperca or just a portion with MTA and the coronal portion with getaperca. Like this is what I did. I applied MTA at perforation site. I have here getaperca and getaperca in this site, and this is the sandwich technique in root repair or root perforation repair. Apply getaperca apical to perforation site, MTA at perforation site, and getaperca coronal to the MTA. And this technique was described by Fabio Gorni in 2011. I'll show you a video how to apply sandwich technique to repair perforations. Using paper point, if you have some bleeding, you can determine the site of the perforation. Now you need to apply your apical plug or down pack your apical getaperca. In that time, you need to apply less amount of sealer so you don't have over extrusion of sealer from this side. Just down pack getaperca apical to the margin of the perforation. And using map system, you can apply MTA at that level using plugger or micro brush. You can compact or adapt Getaberka MTA. Second increment, this is at perforation site. Then you can adapt your MTA. Now you have sufficient thickness of MTA at this site, so the material will be more stable. Then you need to backfill the coronal portion of the canal with thermoplastic Getaberka injection. This is a sandwich technique. Another case, and I'll show you some tricks also in this case, how we manage this kind of perforation. This perforation, the case is referred to me with this Getaberka. This radiograph Getaberka is showing outside, so the dentist referred the case to me to try to remove the Getaberka and fix the perforation. Simply by pre-curving the hand file, I was able to reach to the original canal. Okay, here I can prepare or expand the glide path to size 15, size 20 manually. But what if I want to shape this apical portion using rotary files or nickel titanium files? If you are using shape memory files and you start to go inside the canal, your file will get out from the perforation. It won't reach to this portion of the canal. So how to shape it using rotary files? Here comes the rule of controlled memory files. We need to pre-curve our rotary file before placing inside the canal. Now we pre-curve our rotary file. I can place inside the canal without activation or without rotation motion. After placing in its place, I can start activation to the endo motor and prepare or shape this site. At that time, you need to do this motion in short strokes. Don't take the file up and down in long strokes, so you might get out again from the perforation site. Same for Getaberka. If you try to place Getaberka without pre-curving or pre-bending, Getaberka will go from the perforation site, not in the canal. I'll show you now in this video. This is a file pre-curved. I can place it by my hand or with fingers in place without activation, like I'm doing with manual file. Then I can place my endo motor, my handpiece, and start to shape the canal, as I said, in short strokes, just 2-3 millimeter up and down, up and down. So you can shape the apical portion, or you can go directly placing the file inside the handpiece or the endo motor. It's also pre-curved. This is another case. Now I place the file passively in the main canal without rotation, and at that time I can start my short strokes to shape this portion of the canal, so it would be easy for me to fill the canal with Getaberka or do obturation. And this is the final radiograph. Here I have some sealer skipped from the perforation site. Actually, it should not affect the treatment outcome, but better if it could be avoided. As in this case, here, this is a perforation because of improperly placed fiber post. Here's sinus tract as a perforation site. I removed fiber post using ultrasonics under magnification. Here is the buccal canal. This is the palatal, and this is the perforation site. Here, as I have a more coronal perforation, I can protect the site of perforation by using Teflon during insertion of Getaberka in the other canal. This is a perforation, and this is the canal. I need to protect this portion of the canal during obturation of the main canal. I just get some piece of Teflon, trying to adapt the Teflon using suitable instruments. I just place it as a perforation site having more space in the canal, so I can place my master cone gataperca and adapt it. Now I'm having a space to place my master cone after protection to the obturation, the perforation site. Here is the gataperca in the canal, and this is the perforation. After that, I can simply apply my root repair material, either bioceramics or MTA, to repair the perforation. I'll show you another clinical case in which we used MTA for sealing a perforation in lateral wall of this lower molar. This is the main canal, and here is a perforation in this side. At that time, we need to place our gataperca or did our obturation below perforation level. By gently applying sealer to the master cone on the other side opposite to the perforation, we try to apply our sealer. Here I applied sealer using gataperca. Some sealers are present here. Okay, I applied my master cone gataperca. For sure, I can cut the master cone and place only the apical plug as described in sandwich technique. Now I am doing the down packing using suitable heat carrier tip. I activated the heat carrier after the perforation level, so I don't have any gataperca inside the perforation site. After compaction to this apical plug, I start to inject gataperca or similar size gataperca over the apical plug just below the level of perforation. Here we can see this is similar size gataperca just below. For sure, technique like this or to do this technique in a proper way, you need some sort of magnification. Now I compact gataperca. We can clean the coronal portion of the canal using alcohol or any suitable material if there are any remnant of sealer on the wall. Now we can apply our root repair material or MTA. As you can see, precisely I'm applying the material to the perforation site. I have good control application. I'm using the suitable tool. Now using micro brush, I'm applying my MTA, I'm compacting my MTA. So if I have sufficient thickness in the root to apply MTA, I can do perforation repair only or applying material only to perforation site without using the sandwich technique. However, I would prefer also using sandwich technique in this kind of cases. I apply my MTA, compact my MTA, adapt it. Now I need just to backfill the remaining portion of the canal by using gataperca. Compaction. Now I'm doing 3D sealing to the root canal system. I repair my perforation. You just need to do it till the level, till the orifice level. Just compact or adapt the material. And this is the case after finishing the treatment. Now we come to the end of our presentation. Before finishing, I would recommend you to visit our website, Bob Dentistry. You'll find many lectures, many free presentations, articles, new techniques that you can apply to your daily practice. And it was a great pleasure for me to be part of the new book of Stellarian Endodontics retreatments. Actually, I would like to thank Fabio Gorni, Paio Pertani, and Enrico Casai for this opportunity and what they did. It was great. The book is a new addition to the practice. Many tips and tricks, many clinical scenarios you can find in this book. Soon it will be launched. And thank you all. I hope I was able to deliver something. I was able to help. I'll start to take some questions. Actually, I was not able to see any question during my presentation because of the application, either to see the presentation or myself. So I'll start to take some question. Okay. Let me check questions here. Oh, too much of questions. Wow. Sarah, how to manage C-shaped canal? If you're speaking about perforation, or I'll expand this first. I think now you can see me better. No need for the presentation. Okay. C-shaped canal, you need for cleaning and shaping, you need a 3D cleaning technique and activation to irrigants to be able to reach to spaces that could not be reached by files. Also, you need a 3D obturation technique to fill space, like isthmuses, like the anastomosis between the canals. If you have different anatomy or difficult anatomy not able to reach by conventional techniques, you need to use 3D obturation technique like warm vertical or continuous wave compaction technique. You can use also bioceramics for obturation of this kind of canals, but you need to clean and fill these canals. This C-shaped canal, actually it is challenging, and you need to do proper treatment for this kind of cases. Okay, I'll try to take question only related to my topic because too many questions. Okay, I'll try to check questions here. Okay. Okay, how to stop bleeding from perforation? Bleeding from perforation could be stopped using pressure hemostasis if the area is accessible, using a cotton pallet, moistened cotton pallet. You can do some pressure with this moistened cotton pallet so you can stop bleeding from the perforation. Otherwise, if you have deeper perforation, you can use like anesthesia solution with adrenaline. So you can inject, you have some sort of vasoconstriction at the site of perforation so bleeding can stop. Sometimes, most of the cases I'm seeing with perforation, which is not fresh, I can find the cases with dry site, no much bleeding. If it is fresh, yes, you have much bleeding, but I think this kind of bleeding is healthy and it should be controlled within few minutes with pressure hemostasis or just flushing the site with adrenaline or any anesthetic solution having adrenaline. Dr. Sonia Hamdan, if the perforation can see it in coronal area. Yes, in coronal area, we are not using MTA. Supracrystal perforations, we are not using MTA or bioceramics, just we need to use any restorative material like glass ionomer or composite but you need to have good adaptation of the material. You need to respect the biologic widths. If some sort of crown lengthening or gingivectomy is needed, you need to do in a proper way, not to harm the biological widths of the tooth. For sure, you can use fibrin or collagen sponge in any kind of perforation. The material is resorbable. You just need amount of the material to act as an apical matrix. You can use it for lateral perforations or even for apical perforation or apical open apex. You can use it. But in case of small perforations, which is 2 millimeter, you can have good control on MTA application, so you might not need this material. Bleeding, I answered. Bleeding. Perforation repair first or shaping and cleaning. Perforation repair, I prefer to find the canals first before preparing or treating the perforation. First, you need to find the canals, evaluate the condition of the crown before treating perforation. After finding the canal, you either finish shaping and obturation while you protect the perforation site, or you can seal the perforation site with MTA and you delay the obturation of the canals. Before or after obturation? This is a nice question from Dr. Ibrahim Adil. Before or after obturation? First, the most important point is to seal the perforation as immediate as possible. It means it should be, if the site is ready for treatment, I should end the visit with perforation repair. Before obturation or after, it should be in this visit. If the perforation site is ready to be repaired, I should repair it in this visit. Before obturation or after obturation, it doesn't matter. But don't do obturation and dismiss the patient with a cotton pallet, leaving perforation site open, and dismiss the patient and call him for a second appointment to treat the perforation. No. If I'm doing the treatment on 2 sessions, the first session will be treating the perforation. Sometimes we can find pus or any separation coming from the perforation site. At that time, you need to apply like calcium hydroxide for 1 week to just change the media, change the pH in this media, so it will be more suitable for our root repair material. Then we can apply. More questions. Doctor, if it is okay to apply MTA over bloody perforation, if this blood is fresh from the perforation, it is not old, I think we can use it. No problem with having the fresh blood at the perforation site. But if it is bleeding from an old perforation and you have already these areas contaminated, it is not recommended to use it this way. If it is fresh blood in the site of perforation, MTA can apply it, but it should not be contaminated. This is my recommendation. What about bleeding inside? I answered this bleeding is a perforation, apical third canal after sealing perforation. I think I showed many techniques. Okay. By the way, if you miss any part of the presentation will be available on Teeth Medical Facebook page. So if I see now any question which the answer is present in the presentation, you can go back to the presentation, find the answer to your question. Okay. If we have a small strip perforation, actually I made it during bypassing by file 15. We need PC putty or obturate with bioceramics. For me, I will seal it with bioceramic putty, not with the sealer. even if it is small. Especially if you are doing the repair in another visit. And the same visit, if it is very fine perforation, it might be accepted, but no feedback about using bioceramics for bioceramic sealers for sealing perforations. So it is better to use the material needed. The material which is recommended to be used, we have feedback, we have reviews about to seal this kind of perforation. I think still you can do, if you have very thin small perforation which is fresh, you can seal it during your preparation, during your repair using bioceramic sealer, but I don't recommend also. Could I manage lateral apical perforation with MTA or doing conventional obturation? No. We have destruction at the site of perforation. We need a material which is biocompatible, which have good sealing ability at this site. So you need to use MTA or bioceramic for repairing the material. You can't use getaperca. Okay, I replied this question about the material for supracrystal perforation. When I see perforation before or after, already replied. Can we use biodentine instead of MTA? Sure, you can use biodentine instead of MTA. Okay. Any more question? I'm just checking question which is, the answer might not present in the presentation. Otherwise, you can go back to the presentation. You'll find answer to your questions. How to calculate the price of treating mishaps? Doctor, charge more. Charge as much as you can. When the patient comes to you with mishaps and he knows that you're the one who can do treatment, charge whatever you want. How can you confirm the sponge in the apical third? I'm having good length. The length is I know the working length. I know the margin or the level of the apex. Just I need to adjust this on my plugger while I'm compacting the sponge apical to the margin, and I need to confirm that all the sponge is apical to the margin, no sponge or no fibrin inside the root canal. So after resorption, it might cause it might be a reason for some sort of leakage. Okay. More question. Dr. Sonia, the perforation, we can see, you know. Okay, I already applied this question. I can't see any more questions. Okay, this question from my friend Dima Putin. Why can't bioceramics as sealer can't be used in intra-canal perforations, especially strep 1? I answered this question before, but I said if the perforation is very tiny, string is very tiny, we might think of applying bioceramic sealer during treatment of the perforation. But if large, bioceramic sealer couldn't be used. The material is highly flowable and it can't retain itself in place of large perforation because of the flowability. If we use bioceramic sealers, the flow of the material is high. So how to confirm that the material is stayed in this place perforation if it is large perforation? For small perforation, might be used, but still I am not recommending. I think now no more question. Okay, no more new questions. All are repeated questions. You can go back to the perforation. I'll also check the comments of on this video, and I will reply to any question or any question not answered in the presentation. I will reply to it. Now I think we need to end our live video. I would like to thank you all who attended the presentation, and I hope we can meet each other soon, and this situation will be ended soon, so we'll be able to meet again in conferences, in exhibitions. We can shake hands. So till that time, I wish you all best of luck. I wish you all a happy, fruitful life, and thank you for being there, and see you soon.